The human prostate is a deceptive organ. Under the constant pressure of malignant growth or benign hyperplasia, the gland's internal architecture distorts, shifting against the rigid confines of the pelvic floor. In the modern clinic, the MRI functions as the master surgical map for navigating all pelvic interventions. But a map is only useful if everyone reads it the same way. When radiologists rely on generic anatomical terminology, they create ambiguities for the urologists and surgeons executing the procedure. To provide actionable data, the prostate must be viewed through distinct lenses. Its anatomy is mapped using specific criteria dictated by the pathology: oncology, benign prostatic hyperplasia, or infection. Mastering these three clinical contexts makes the radiologist a primary architect of the patient's surgical plan. Accurate mapping begins with the correct acquisition plane. Magnetic resonance imaging protocols mandate obtaining slices either straight to the patient or in an oblique axial plane, aligned perfectly perpendicular to the posterior peripheral zone. This MRI scan demonstrates why alignment matters. Excessive angulation of the imaging plane skews localization. As a result, the anterior aspect shows the bladder wall, marked by the blue arrow, while the posterior aspect displays the apical peripheral zone, marked by the green arrow. Once the plane is set correctly, the gland is mapped using the McNeil zonal anatomy framework. This system is the gold standard for predicting oncologic risk based on tissue origin. The McNeil model divides the prostate by glandular composition. The peripheral zone, where the majority of cancers originate, wraps around the posterior and lateral edges. Inward from that, the transition zone surrounds the prostatic urethra. At the superior base of the prostate lies the central zone. This is a specific, cone-shaped region of tissue that surrounds the ejaculatory ducts as they travel to merge with the urethra. Historically, reports often lumped these areas together, using terms like central gland or anterior gland. These legacy terms contradict modern PI-RADS scoring systems, risk misinterpretation, and should be completely avoided. However, the McNeil zones do not apply to all surgeries. Urologists rely on an older lobar framework, dividing the gland physically relative to the urethra into distinct right lateral, left lateral, and median lobes. To communicate effectively, a radiologist must code switch. They utilize the McNeil zones for pinpointing cancer locations, but adopt the urologic lobar framework when planning physical interventions for benign conditions. In the context of oncology, surgical success is defined by a set of outcomes known as the pentafecta. The primary goal is total oncologic control, balanced against the preservation of the patient's continence and erectile function. Meeting these goals depends heavily on mapping the pseudocapsule. This is a thin layer of fibromuscular tissue forming the definitive boundary between the prostate gland, the surrounding periprostatic fat, and the neurovascular bundles. This T2-weighted MRI begins our evaluation of the extraprostatic extension, or EPE, risk spectrum. The yellow arrow points to a lesion that merely touches the pseudocapsule. Because the abutment is narrow and the capsule is undeformed, the perceived risk of tumor extension is low. On this scan, the risk increases. The lesion now broadly contacts the glandular margin, exerting outward pressure to create a smooth capsular bulge. In this slice, the indicators become high risk. The boundary loses its clear definition. The irregular bulging and spiculation seen along this margin suggests the tumor is infiltrating the surrounding connective tissue. Finally, we see unequivocal extraprostatic extension. The tumor has breached the fibromuscular boundary entirely, extending into the periprostatic fat and reaching the adjacent rectal wall. Assessing these margins requires high precision, because normal internal structures often mimic malignancy. Both the central zone and the anterior fibromuscular stroma are naturally dense and appear dark on T2-weighted imaging, appearing exactly like a tumor. This MRI demonstrates a dangerous diagnostic trap. The large white arrow points to a symmetric, dark midline lesion that closely resembles normal central zone tissue.
However, this is actually a biopsy-proven cancer, mimicking normal anatomy. Contrast that symmetrical mimic with the lesion shown here. The white arrow indicates a dark, homogeneous mass that disrupts the normal architecture of the anterior mid-gland, qualifying it as a true PI-RADS 4 cancer. To confirm malignancy, we analyze the multiparametric data. On this high B-value diffusion-weighted image, the identical spot shows marked restricted diffusion, represented by the bright signal. Returning to that deceptive posterior midline lesion, we see its dynamic contrast enhancement sequence. The focal, early, and avid enhancement verifies the true malignant nature of the tumor. Accurately predicting extraprostatic extension dictates surgical approach. These findings determine whether a surgeon spares or resects the neurovascular bundle, directly impacting the patient's postoperative quality of life. When evaluating benign prostatic hyperplasia, the anatomical focus shifts inward. In BPH, hypertrophy inside the transition zone weaponizes the prostate against the urinary tract. As these BPH nodules expand in the center of the gland, their outward pressure condenses the surrounding healthy tissue. This constant physical expansion creates an internal boundary known as the surgical capsule. It is vital to distinguish this inner surgical capsule from the outer pseudocapsule. Advanced enucleations, like the hole-up procedure, trace this inner surgical capsule to core out obstructing tissue, while leaving the outer peripheral zone intact. The distribution of these expanding lobes determines the severity of the mechanical obstruction. In type 3 BPH, the hypertrophy forces a large median lobe to protrude superiorly, pushing directly into the bladder space. This creates a severe operational hazard. As the median lobe herniates upward, it displaces the bladder trigone, putting the ureteral orifices in the path of lasers or scalpels during transurethral interventions. Understanding this lobar origin also dictates hardware choices. Prostatic urethral lift implants pull hyperplastic lateral lobes away from the urethra, but their deployment geometry is unsuitable for an obstructing median lobe. For radiologists, pre-existing hardware creates significant diagnostic blind spots. The metallic composition of these urethral clips generates susceptibility artifacts that can obscure up to a third of the transition zone on diffusion-weighted sequences. BPH imaging focuses on physical, mechanical obstructions. The radiologist engineers a roadmap to safeguard the adjacent plumbing. The third and final clinical context we must evaluate is infection. Acute bacterial prostatitis frequently strikes the peripheral zone, presenting as a focal area of T2 hypointensity that structurally mimics an aggressive carcinoma. Because the visual overlap is high, differentiating a true prostatic abscess from a tumor requires a specific multiparametric signature. On imaging, an abscess presents as a multiloculated, thick-walled fluid collection. The key diagnostic markers are marked diffusion restriction within the fluid itself, coupled with a thick, peripherally enhancing rim on contrast sequences. These acute infections must be distinguished from benign midline anomalies, like utricle or Mullerian cysts. Those are structural fluid collections with distinct embryological origins, lacking the aggressive inflammatory signatures of an abscess. Radiologists must also avoid confusing a thick-walled abscess with the benign cystic degeneration that develops inside aging BPH nodules. Misinterpreting an active abscess as a necrotic tumor or a harmless cyst guarantees the wrong clinical pathway, resulting in either a dangerous surgical delay or an unnecessary biopsy. The prostate is not a uniform block of tissue. It is a compartmentalized organ, bound tightly within a framework of nerves, vessels, and functional sphincters. Adhering to a standardized, precise anatomical lexicon is the bedrock of safe urologic surgery. Every measurement, margin, and zonal assignment on a scan dictates where a surgeon places a scalpel, fires a laser, or spares a nerve. Ultimately, matching the anatomical lexicon to the specific disease, cancer, BPH, or infection, transforms the MRI into a definitive surgical roadmap.